Thank you, Father Michael, and thank you to the Walsh University Chorale for that moving performance. It is now my honor to introduce to you Dr. Nicole Labor. Today's theme centered on breaking the stigma. How do we shine a light on the behavioral health needs in our community so that we may work to address those needs? Our next speaker does just that, and her personal story brings to life the reality of addiction and recovery. She graduated from Pennsylvania State University with a Bachelor's of Science degree in Biobehavioral Health and attended graduate medical school at the Lake Erie College of Osteopathic Medicine. She completed a residency in family practice at the State University of New York in Buffalo, followed by a fellowship in addiction medicine at Geisinger in Pennsylvania. She is currently the medical director of 180, a treatment center that offers inpatient and outpatient chemical dependency and behavioral health services in Worcester. She is also the director of addiction medicine fellowship for Summa Health System. Dr. Labor spends her time educating healthcare professionals, churches, and people like us on the disease of addiction and works to remove the stigma surrounding addiction. She and her husband live with her daughter on their small farm, and it is now my honor to introduce to you Dr. Nicole Labor.
Hi, everyone. Anyone that's seen me before knows that I usually like to walk around the stage, but I tore my ACL on Friday, and they tell me I'm not supposed to do that. So I'll be standing here. So primarily, let's see. Okay, so those are my qualifications. I work at 4 different treatment centers for addiction. That's pretty much all I do is treat addiction all day, every day. But so why this talk? I am asked to give this talk most frequently, primarily because it's very clear that as a society, we don't understand addiction. We call it a disease, we get reimbursed from insurance companies for treating a disease, and nobody bothers to explain why it's a disease. How does it qualify as a disease if people have choice, and a lot of the symptoms of the disease are behavioral. So I would give talks on specifics, a specific drug or a specific type of treatment. At the end, I would get a lot of questions from people that indicated that they really just don't understand addiction. So that is where this talk originated from. As a society, we don't treat it like a disease. I get people saying things to me like, oh, sure, it's a disease, but it's not like cancer, right? That's everybody's favorite comparison. It's not like cancer. And, when someone who is diabetic chooses to eat a piece of chocolate cake knowing that they could have a seizure and die, and they do so, nobody talks about how their kids are better off. But every time an addict overdoses and dies, there's somebody waiting in the wings to talk about how their kids are better off without them. So we really have a stigma. There really is a judgment around the disease of addiction, and I think one of the best ways to combat that is to educate ourselves about why it's a disease. It's easier to have compassion if you understand what's going on. And the opioid problem that has been sort of ongoing has made it more difficult for me because addiction is a disease of the brain and it has very little to do with a specific drug. And if we continually focus on one specific drug, then we're ignoring the overall picture of the disease. And that's what continually happens. We keep saying there's an epidemic of this drug or that drug, and we focus on legislation and treatment of that specific drug, and it gets under control and another one pops up. So I always say it's like that whack-a-mole game where you whack one mole and another one pops up. That's what keeps happening, and I think that we need to focus on how we unplug the machine instead of continuing to play the game. And if you don't believe me, here's the cycle. In the 1980s, we had a cocaine epidemic where women were dying, pregnant women, a lot of pregnant women were losing babies and were winding up in the ER with complications from cocaine use. In the early 2000s, we had the methamphetamine problem. People were blowing themselves up, making crystal meth. We had all those crystal meth labs going on. So we had the Combat Methamphetamine Act of 2005, which basically put Sudafed behind the counter at Walgreens, so you need your license now to get cold medicine. That was our solution to that problem. And in cutting down on access to making meth, emerged the bath salt epidemic, where we had people eating people's faces and doing weird zombie-like things. So we made bath salts illegal. So my point is, we just continually we continue to focus on the specific drug instead of the treatment for the disease of addiction, which is really where the focus needs to be. It's not the first time we've seen opiates. In the 1800s, we had morphine prescribed to everyone. In the early 1900s, heroin was prescribed to everyone. And then in the 50s to the 70s, there was a huge illicit heroin epidemic, but it primarily affected minority populations, so it didn't get the attention that it really deserved. And then, of course, we had the cocaine and the meth and the bath salts, and now here we are again at opiates. So addiction comes from a Latin word meaning to give over into slavery, which is kind of an accurate term considering what's going on in the brain. The brain really becomes a slave to itself. But in medicine, so this is really what it comes down to. So in medicine, in order for something to qualify as a disease, it has to fit into the medical model that we call the disease model, which is a very sophisticated name. They're really creative in medicine. So it's called the disease model, and basically what it says is that in order for something to qualify as a disease, there needs to be an organ. That organ needs to have a defect, and the defect needs to demonstrate symptoms. So in the case of diabetes, the organ is the pancreas, the defect is a decrease in beta islet cells, the symptoms are high blood sugar, eye disease, kidney disease, et cetera. Cancer, which is everybody's favorite comparison, let's say liver cancer, the organ is the liver. The defect is an overgrowth in normal liver cells out of control, and then the symptoms are liver failure, jaundice, big bloated belly, whatever. So the question is, how do we get addiction to fit into this model if we're calling it a disease? So to start, it's a brain disease. Okay, it originates in the brain, and the actual dysfunction, the biological dysfunction, occurs in the brain. So we're at a disadvantage because we don't really understand the brain very well. Even brain experts don't understand the brain very well. And we know that every emotion, every thought, every behavior, everything that we do, think, and feel originates from the brain. And so it seems logical to say that if there's a defect in the brain, that it could affect any of those things. It could affect the way we physically feel, mentally feel, emotionally feel, spiritually feel. We know that there are times where someone suddenly becomes a totally different person. Their personality changes. They become aggressive or impulsive or angry, and then we find out they have a brain tumor. All of their symptoms were behavioral. And when we found out they had a tumor, we had a lot of compassion for them. But yet all we experienced individually was the symptoms of that. And addiction really falls into the same category. Most of the symptoms are behavioral. And so we have a tendency to sort of judge them as bad people because their behaviors are bad without understanding the biology behind them. So there's two parts of the brain that I always talk about and that I think that the world at large needs to understand. So the two parts of the brain I talk about are the frontal cortex and the midbrain. So the frontal cortex is the part of the brain that makes you you. It's the part of your brain where your personality is, where your values, your morals, your spirituality, your willpower, your choice. It's conscious, you're aware. It's where your thoughts arise from. Okay, and I need pictures to make things simple, so that's why there's pictures. So Superman is the representative of the frontal cortex because that's where all our superpowers are. That's where our talents are. That's where our skills are. That's where our abilities are. So a fully functioning Superman is a fully functioning frontal cortex, and then the kryptonite Superman, that's like a cortex that's been sort of beat down over time. The other part of the brain is the midbrain. So the midbrain is deep inside, it's primitive, it's completely subconscious, you have no control over your midbrain, and its entire function is to keep you alive as an individual and as a species. So it's this life or death processing station. When you're faced with a scenario where your life is in jeopardy, the midbrain activates and it compels you to act in a way that it believes is going to save your life in that situation. So that's really all it does. You cannot access this part of your brain at all. It's only active during times where life is in jeopardy. And so I use the tiger. So the angry tiger is a midbrain that feels threatened. It's your brain says, oh my God, we're gonna die. We're being chased by a bear and we're gonna die. So the midbrain activates, the tiger gets angry. The sleepy tiger is the midbrain that doesn't feel threatened. And most of us go through most of our lives with a sleepy tiger. So the midbrain has three functions, really, to eat nutrients and drink water, to kill off or run away from any predators, and to procreate for the perpetuation of the species. So the midbrain will activate when any of these things are threatened. When a baby is born, one of the first things we do is we feed it. We do that because food, nutrients in food, will activate the reward system in the midbrain and tell the midbrain this is necessary for survival. So the midbrain will catalog that information away, and a baby will feel hunger, which is an activation of the midbrain saying we need nutrients, and that's how the baby craves food. So drugs, and when I say drugs, please understand that I mean all addictive drugs, including alcohol. So alcohol, marijuana, benzodiazepines, barbiturates, opiates, cocaine, methamphetamine, any other stimulants, okay? So anything that people can get addicted to qualify as a drug that works in the midbrain. And we know that because they did experiments where they would take probes and put them into mice brains and allow the mice to self-administer cocaine to their brains. And they found that the mice that administered cocaine into the cortex did not want any more cocaine. They didn't get any reward from it. But the mice that had a probe in the midbrain would actually hit that lever and give themselves a dose of cocaine over and over and over until they died. They wouldn't eat, they wouldn't take care of their little mouse children, they wouldn't play with other mice, they wouldn't do anything except administer cocaine over and over until they died, which is very similar to what we see in the human population, is people will use drugs and ignore their responsibilities and ignore the things that we think they should be doing as a member of society. So mice behave in the same way. Mice get addicted to drugs, but they don't come from bad homes. They don't even have a frontal cortex, so it's not a matter of morals or ethics or values. So that was really the start of the study of the disease of addiction in the brain. So what happens with repeated use of a substance, an addictive substance, is that midbrain gets exposed over and over and over to a highly rewarding chemical. And the brain responds to that in some people by actually reconfiguring in such a way that it starts to believe that that rewarding chemical is necessary for survival, just like food and water and running away from predators and whatever. So that is really where that happens. I'm going to explain how that happens. But for people who have never been addicted to anything, the example I always use is, imagine you're in the desert and you're on day 5 with no water. You haven't had water in 5 days. So your organs are shutting down. You're going to die. You're not going to live another 24 hours. And I approach you with a bottle of water. And I tell you, you got to drink this water, but I'm going to take your kids and your job and your bank account and your house. There is not a person on earth in that scenario who's biologically capable of refusing my water. Everyone in this room, everyone I've ever met in my life would biologically have no choice. You would take the water. You would give up all those things. And that is because in times of dire need, when the midbrain is active and saying we have to stay alive, your frontal cortex actually shuts down. And your frontal cortex is where you value your kids and your job and your house and everything. And when that is shut down, you can't access it. And so the only thing going on in that moment is your brain saying, we feel terrible, we're dying, we have to fix this, and water is available, so drink that. You would drink the water, you would satiate that midbrain, your frontal cortex would come back on, and you'd be flooded with guilt and shame because you gave up everything you valued just to get a bottle of water. And then you'd spend the next hour trying to convince me to give you your stuff back. But essentially, this is what happens in an addict's brain over and over and over when they feel the compulsion to use drugs. So there is a scenario where someone can use drugs for a really long period of time and then just stop using drugs and never use again. That is not addiction. Okay, addiction actually has to do with the conformational change in the brain. There has to be a biological change in the brain for it to be true addiction. Now, if you put that person in a brain scanner and you put a true addict in the brain scanner, you could see the difference. You would see activation in the midbrain and a decreased activity in the cortex in a true addict. I put that in here because I think people need to understand, like, there are a lot of people out there who like to say, like, just stop. Just use willpower. Why can't you just stop? I stopped. I used X, Y, or Z for 10 years and just gave it up. And all you need is good willpower and to be strong, right? If you don't have a gene for addiction, Or if your gene wasn't activated and the change in the brain that I'm talking about didn't occur, you don't have addiction. Doesn't matter how long you used or what you used. Okay, so that does happen. The problem is, of course, we can't put everybody in a brain scanner and see if they're using if they're addicted or not. So we assume everyone that's using drugs is, but what I'm saying is if you know someone that was able to just stop, walk away, and never use again, don't assume that everybody else can do that. So if you Google brain on drugs, you'll get images of that frying pan with the eggs from the 80s, remember that? And then you'll also get these images. So these aren't anything specific to anything I'm doing, but they're good images. So on the far, your left, you'll see the brain, a normal brain has all that activity, that red, that's activity in the brain. And up towards the top of the screen, that's the frontal cortex, okay, because we're looking down on the head. And the cocaine addict, there's way less activity in that brain. And then over here, we see a normal brain, and then you see a cocaine brain 10 days after they stop using and 100 days after they stop using. So, and this would continue out for up to 2 years before we would see normal activity again in someone who stopped using. So this is why when addicts stop using drugs for like 5 minutes or a week and they say, oh, I don't feel better, I might as well I might as well keep using if I'm gonna feel this terrible. Well, it takes some time for the brain to heal. And so it's gonna take time for them to feel better. And then this is the the midbrain. And in the control brain, in the normal brain, you see all that red, that's dopamine receptors. And then in the addicted brain, you see there's far fewer dopamine receptors. But the important part of this slide is if you look at what drugs are there, you can see that it doesn't matter. All drugs do the exact same thing to the brain. Once this change has occurred and someone has become addicted, all drugs are interpreted by the brain exactly the same. So it may have been alcohol that caused someone to start having problems with substances, but once that occurs, once we see this change in the brain, any substance that is addictive will cause the same thing over and over. So this is why it's very problematic in the healthcare field and even in society understanding there's no such thing as I haven't used heroin in 10 years, but I still drink. That's not recovery. There's still, the disease of addiction is still going on actively. So addiction is a broken pleasure sense. It's a broken reward system. The reward system is in the midbrain, and it gets broken. So here's how our brains work. This is like super simplified times a billion, for me, mostly, not for you. So our brains are little manufacturers, and they make neurotransmitters. Right, so they make chemicals in their cells, and they store them in little vesicles, and they make dopamine, and they make acetylcholine, and they make serotonin, and they make GABA, and they make glutamate, and you've heard of some of these, right? You know, neurotransmitters. So the brain makes these and stores them. We receive a signal, either an electrical or a chemical signal. So an electrical signal would be something you see, hear, smell, taste, all right? You receive a signal. Or you eat, drink, or take a drug. That's a chemical signal. That signal comes in, and it tells that first brain cell, release the neurotransmitters, whatever is appropriate for that particular stimulus. So that brain cell releases neurotransmitter, and then that neurotransmitter is picked up by receptors for it on the next brain cell. That brain cell then sends a signal out saying, here's the effect. So you're walking down the street, I see a hole in the ground, I receive an electrical signal through my eyeballs from the light of the sun and what I'm seeing visually. That electrical signal triggers my brain cell to release acetylcholine. The acetylcholine then binds to the next brain cell and sends out a signal to my leg and says, take a step. Okay? That's how our brains work, again, super simplified times a billion. But what that means is that ultimately it doesn't matter what the originating stimulus is. What matters is what neurotransmitters are released and what their effect is, okay? So if I use alcohol or cocaine or heroin, it's gonna tell that first brain cell to release a bunch of neurotransmitters. It's those neurotransmitters that actually cause the effect. So if I use a stimulant, such as cocaine, it's going to release a bunch of stimulating neurotransmitters. And they are going to bind, and I'm going to get an increased heart rate, and I'm going to get sweaty, and my pupils are going to dilate, and I'm going to have a lot of energy, and I'm going to be really hyper, okay? Because those neurotransmitters cause that. Cocaine also releases dopamine. Dopamine is a pleasure chemical. So I will get a bunch of dopamine released, and that tells me this is kind of good, I like this is comforting, it's enjoyable, whatever. When I use heroin, I release a bunch of sedating chemicals. I release a bunch of analgesic chemicals, so I get pain relief, I get sort of more sleepy, for some people they get energy, but that has to do with the neurotransmitters that are released that are causing an effect. But heroin also releases dopamine, the pleasure chemical. Alcohol, same thing. Marijuana, same thing. Benzos, same thing. So you get my point. My point is they all release different neurotransmitters, which is why people can tell you, I know if I took this drug versus this drug, right? But what they don't realize is that at a subconscious level in the midbrain, all of those drugs are releasing dopamine, and dopamine is what we become addicted to. We have 10 perceptual systems in the brain: vision, hearing, touch, smell, and taste. Everybody knows. 6 through 9 are for people that like physics. And then 10 is the pleasure construct. So we need pleasure to live. That baby needs to get pleasure from nutrients when it's first born, or it will not crave nutrients and it will die. We need to have pleasure to get up in the morning and thrive. Imagine if you never had any joy or happiness in your life, if you never enjoyed anything, we would have died off as a species a long time ago. We need pleasure to live. Dopamine is that pleasure chemical. Dopamine is the chemical that is released when your kid gets on the honor roll, or when you get a promotion at work, or you win a lottery ticket, whatever. So whenever you're happy or having fun or enjoying something, it's because dopamine is released in conjunction with that. And this can vary from person to person. Obviously, some people enjoy playing musical instruments. If you were to hear me play a musical instrument, you would not enjoy it at all. It would be awful. And I don't enjoy playing musical instruments, so I don't do it. I don't practice it. I don't seek it out, right? Some people are great at sports. Again, not me, obviously. So, if you enjoy something that makes you unique or is a unique hobby to you, it's because dopamine is released when you do that activity. And we have a threshold for pleasure in our brains, which means we have so many receptors in our brain for dopamine, and they say this many of them have to be filled in order for us to enjoy this. So again, I may release some dopamine when I pick up a guitar, but it's not enough to cross my threshold and say, I want to do this again and again. But for somebody else, that may be the case. So we all have a threshold, and natural activities release certain amounts of dopamine, and if it crosses your threshold, you enjoy that activity. Now, drugs, abusive drugs, release massive, unnatural amounts of dopamine, and in huge spikes. So they get this huge spike of dopamine, and it's more than anything natural. And what happens is our brains will compensate for this activity. Our brains will say, hold on, we are being dumped on with dopamine here, and we can't handle all this dopamine, and since it's always here, we might as well kill off some of these receptors and put our energy elsewhere. And so it starts taking away dopamine receptors, because you don't need as many when the chemical's always available. And when it takes away dopamine receptors, what happens is you now need more dopamine to cause the same amount of pleasure. The threshold for pleasure moves up. Biologically, there are fewer receptors, but graphically, it essentially looks like this. The threshold for pleasure moves up. So you can no longer enjoy things that used to be enjoyable, because playing the guitar or playing a sport still releases the same amount of dopamine as it always did, but it's no longer enough to cross the new threshold. And so that's not enjoyable. So anybody here knows an addict who used to love to do something, right? Someone who's actively using who used to love to do something. They don't anymore. That's because actually biologically, they don't enjoy it anymore. They're not getting any pleasure chemical from that activity anymore. Chronic and severe stress is very important in the study of addiction, because chronic and severe stress looks almost identical to addiction in the brain. So chronic and severe stress, and I'm not talking about like, oh, I can't pay my electric bill this month. I mean trauma. I mean significant chronic and severe stress will cause our bodies to release a hormone called corticotropin releasing factor, CRF. When we have high levels of CRF circulating in the system, our brain responds by taking away dopamine receptors. I don't know why that is. It's an evolutionary response. I'm sure somebody knows why, but I don't know why. But that's how our brain responds to high levels of CRF. And for those of you that were listening 8 seconds ago, you'll remember that that's exactly what happens in addiction. You get rid of dopamine receptors. And so what that means is that someone with chronic and severe stress also needs higher levels of dopamine in order to feel a normal amount of pleasure. So their threshold also moves up and they can experience joy like a normal person. So why is this important? 1 out of every 4 addicts has a history of chronic and severe stress in the form of trauma. So let's say there's a child who's experienced some significant childhood trauma. They don't know how to properly cope with that. They're genetically predisposed to start producing high levels of CRF. Their threshold for pleasure moves up. They're exposed to some sort of drug at the age of 9, 10, whatever, and for the first time in their lives, they feel normal. They feel pretty good. And they didn't even know that was a possibility. And so they continue to seek out that substance to feel that way, because that's our natural response. And so then now they continue to use the substance over and over and over, and their dopamine receptors further downregulate because they're using substances. And so now they're constantly looking for drugs, looking for money to find drugs, living a pretty stressful lifestyle in order to get drugs. So now they have chronic and severe stress as a result of the addiction. On the flip side of that, if 1 out of every 4 addicts has trauma, what about the other 3? So they don't have a history of chronic and severe stress. However, they start drinking alcohol. That's usually where it starts, but it doesn't matter. They started taking a prescription pain medicine or whatever. They're hanging out with their friends. They're partying in a way that they feel is normal and healthy, and they continue to go on and they party harder maybe than some of their friends. And then the time comes and they're out of school and their friends move on and get jobs and wives and lives, and they didn't even graduate because they're partying too hard, and now they're living in their mom's basement and they can't hold a job except maybe at the Circle K sometimes, and they can't hold a relationship, so they're constantly at the bar drowning their sorrows because the substance has become their coping skill. Their life is chronically and severely stressful because of their addiction. So stress leads to addiction, which further perpetuates stress. But addiction will also lead to stress, which will perpetuate the addiction. So it becomes a huge and vicious cycle for people. Anhedonia is the term we use. It's this pleasure deafness. So addiction is a stress-induced hedonic dysregulation. It's a broken pleasure system due to unmanaged stress. Glutamate is the other neurotransmitter I like people to understand, because glutamate is the neurotransmitter responsible for memory. So glutamate is the executive assistant to dopamine. So every time dopamine is released in a pleasurable situation, glutamate comes along and says, let me write this down. I'm going to take notes about this. And glutamate is such a good executive assistant to dopamine that anything surrounding a pleasurable activity will also wind up in the file. So first time someone uses a Percocet, glutamate says, oh, Percocet's awesome, I'll write that down. Then the next time, glutamate says, oh, Percocet comes in an orange bottle. Orange bottles are awesome. And orange bottles come from the guy in the white coat. White coats are awesome. Pharmacies are awesome. The house on the corner of 1st and 3rd is awesome, right? And it just creates this bigger and bigger file surrounding the access to this dopamine. And that becomes really important later, especially when you're trying to treat the disease, because relapse is caused by 3 things in humans. 1 is dopamine exposure, okay? So we have 2 areas where this is really problematic. 1 is healthcare. Doctors and healthcare providers do not understand addiction. They do not understand all of the things I just told you, and so they have the same misconceptions as the addicts themselves, that if you use one substance, you're safe from the others. And so they do things like, oh, you're an alcoholic, well, it's okay for me to give you Percocet for your pain. Or, oh, you're a heroin addict, it's okay for you to have Xanax for your anxiety. And they don't understand that the dopamine released from those drugs are exactly the same. And the addict brain does not know the difference. And so it puts them at super high risk of relapse because they're being exposed to that high level dopamine over and over. And this isn't to say if someone's having a heart attack, you should withhold the life-saving pain medicine, fentanyl or morphine or whatever your hospital uses. That's absolutely necessary. It still puts them at risk for relapse. but it's a risk-benefit scenario. You have to look at the benefit of saving their life from a heart attack is more important than the risk of them relapsing. However, if they show up in the ER with a sprained ankle, the risk of them relapsing from a shot of Dilaudid is probably higher than, or less scary than the risk of them relapsing. So really need to use caution when using chemicals. The other area we see dopamine exposure causing relapse is with family, well-intentioned family members. You know, family doesn't understand addiction. This is why in the field of treatment of addiction, we tell people you need people in your support system that are other addicts in recovery. Because it doesn't matter that your family is really supportive and doesn't use. That's great, lucky you. You know, that's an awesome thing to have. That will not help, though, because they don't understand the disease. And so it's usually a well-intentioned family member that says, you've been clean from heroin for 6 months, you're at your cousin's wedding, you can have a glass of champagne. Or you haven't smoked crack in almost a year, it's totally okay for you to drink a beer with your dad while you watch a football game, right? Because those things seem less pernicious, they're less horrible. And so that's where the process of the relapse will start. The second thing that causes relapse is stress. You know, chronic and severe for sure, but really any stress, because once you're at the point of addiction, any stress can be viewed as pretty chronic and severe. But anybody knows an addict who got clean for a period of time and then relapsed, you ask them what happened, what do they tell you? Something stressful. Usually dog died, mom died, wife left, lost my job, right? Something like that. And then the third thing is drug cues, and this is where the glutamate came in. People, places, and things. Walking by the pharmacy where that guy with the white coat gave you the orange bottle will cause a small release of dopamine and remind the brain, because glutamate kept such a good file, that that thing is associated with dopamine. And so people are triggered by just being around other people they used to use with. This is why it's very hard for two addicts that are in a relationship to get clean together, because both of their brains are wired to associate that person with their drug use. So the midbrain believes it needs high-level dopamine to survive. It believes it needs these substances just to survive. It's number one on that list of survival mechanisms. So how does it motivate these people? And most addicts are really good people from good homes with good value systems, right? How does it take those people and turn them into what we see as addicts, the bad behavior? And the answer is craving. So when you were in the desert on day 5 with no water and your midbrain was active, that's a craving, okay? Craving's not like, I'm pregnant, I want pizza, right? That's legit, but that is not a craving. A true craving is the midbrain being active and saying, I absolutely feel wrong, and we need to fix it. I need to feel right. So it's not a conscious thing. There's no addict walking around going, you don't understand, my midbrain is really craving dopamine right now. But they feel uncomfortable. They feel so overwhelmingly uncomfortable that they have to escape that feeling. And that is what that tunnel vision, that compulsion to just feel different than they feel in that moment. That's what a true craving is. You know, and the choice argument has always been, well, if you put a syringe of heroin in front of a heroin addict and you tell them you're going to shoot them in the head if they use it, they will choose not to use the heroin. So they obviously have a choice. And the answer is yes, behaviorally they can make that choice, but what they don't have a choice about is for the next 2 weeks they are going to be restless, irritable, discontent, and absolutely miserable, and they're not even going to know why. It is because that midbrain got activated just looking at that syringe full of heroin. They cannot choose to have a craving. True craving without access is suffering. It is true suffering. And you're taking a group of people who now need high levels of dopamine just to feel normal. So they have no ability to self-soothe. They can't make themselves comfortable from a completely uncomfortable state. And so now they're uncomfortable and they don't know what else to do. So they eventually wind up using if they're not in recovery. So once this craving sets in, once your tiger is angry, what happens? I'll tell you what happens. It sneaks into your shut down cortex like a ninja. And it sneaks in there and it goes through the files. And it looks for the thing in the cortex about you or about the addict that it thinks will make it okay to use again. Pain. Oh, I have terrible pain that I haven't addressed in 10 years. Or, oh, I have terrible anxiety. I forgot that I can't even leave the house without Xanax. Or my life is extremely stressful. Or whatever. It's looking for that thing that we hold most dear. And when the craving passes, and it will pass with time or with use of a substance, for addicts in active use, it passes and comes right back, right? But it will pass. Once it passes and the cortex comes back online, the thing staring them in the face is that thing it found. And so now the addict says, well, yeah, I have to work in order to support my family, and if I don't sleep, I can't go to work, and I can't sleep, so I can have a drink, right? So now they have some sort of justification. They have some sort of rationalization. They have some sort of reason for making it okay, which is essentially rendering willpower useless. Because willpower only keeps us from doing things if we think it's not okay to do it, right? But once we have permission, willpower is irrelevant. So addicts have lots of willpower. In the moment of craving, though, it's useless. And so ultimately, they wind up feeling justified in having to lie and manipulate and cheat and whatever else they do, because nobody understands. Nobody gets it. Nobody knows what I'm going through. But these are what we see, right? These are those bad behaviors that we see. And these are the things we judge. We don't see the fact that they don't have dopamine receptors in their midbrain. We don't see the fact that they can't get through a day without feeling like they're essentially being chased by a bear or dying of thirst. So this is super sophisticated. Try and follow along. I am not a geneticist, so this was explained to me by a geneticist, so I'll explain it to you the way it was explained to me, because it's complicated. In order for you to have addiction, you have to have a gene for addiction. In order for you to have lung cancer, you have to have a gene for lung cancer. If you don't have a gene for lung cancer, you could smoke 80 packs of cigarettes a day for the rest of your life. You'll have terrible lung disease, but you will not get lung cancer, okay? You have to have a gene for addiction. Most people have at least one. I think the true statistic is somewhere between 60 and 70%. I usually just make up statistics, so I say 90%. But I think around 70% of all people have at least one gene, okay? Many people have more than one gene. Genes are activated by specific drugs in specific quantities. We don't know. I can't pull out everyone's DNA and be like, you, methamphetamine, 12 uses, you're going to be addicted. There's no way to do that, but that's essentially what happens. And so you have no idea if you have a gene for addiction and it's triggered by one use of alcohol. That first time you choose to use alcohol, you turned your gene on. So that's why, for me, the argument about first choice fails, because I don't know very many people who didn't do anything one time, okay? And you never know if that one time is going to be the time that gets you addicted. It could be 7,000 times. Maybe you need to use Percocet 7,000 times before you become addicted. You trigger this gene. If you never use Percocet 7,000 times, you're never going to become addicted. However, once this gene is turned on, once those dopamine receptors start down-regulating, which is what happens when the gene is turned on, now all drugs will cause the same thing. So even though it took one specific drug to turn the process on, now any addictive drug will continue the process. And again, this is where we run into a lot of trouble. People think, I drank alcohol for 10 years, put it down, walked away, never touched alcohol again for 8 years, then had knee surgery, took Percocet for a couple of weeks, got addicted, wound up on heroin, wound up in detox, and they don't understand why they can't drink alcohol again. But it's because alcohol didn't cause the addiction, the Percocet did, but now that it's there, alcohol will actually do the exact same thing. It will downregulate the dopamine receptors in the brain. So once you're addicted to one substance, you're addicted to all substances, whether you like it, whether you've ever used it, doesn't matter. And then I put this in here because I think people need to understand this too, because they asked me about it. Process addictions. Process addictions are the behavioral addictions: video game addiction, sex addiction, shopping addiction, pornography addiction, gambling addiction, food addiction, right? There's everything. So what happens is, for some people, they stop using drugs. And remember that while their threshold is that high, they cannot experience joy and pleasure from normal things. So if we take away their drugs, there's a period of time while their threshold is moving down to normal that they cannot experience joy or pleasure. So I say every single addict who is getting clean should have a period of time where they appear depressed. They should appear dysthymic. They should have some degree of depression going on. It's not to say that they also don't have an organic depression related to serotonin. They may have that as well. But every addict should have some period of time where they're depressed while that threshold's coming down. Now, that threshold's coming down and suddenly someone realizes when they go to the casino they feel better. Or they realize if they exercise 4 hours a day they feel better. Or if they eat a ton of chocolate cake they feel better. And what happens is they continue that behavior. And then that behavior becomes compulsive and their threshold for pleasure stops there. And they get stuck there. And then that behavior becomes no longer available. They run out of money, they break their ankle, something happens, and that behavior is taken away from them. Now their threshold is still stuck there. But guess what they weren't doing while they were exercising 4 hours a day? They weren't working on their cortex at all. They weren't strengthening the coping skill mechanisms. They weren't learning how to deal with life in general. And so they can't go to the casino anymore, and then something terrible happens, they have no coping skills, and they go right back to using. And so these behaviors can be problematic. Now, they don't work the same as drugs. They're not like universal. But it's something to be aware of, it's something to be vigilant about. If it's causing a problem in someone's life, it's probably a problem. But the goal of treatment, the goal of all treatment, is to strengthen that cortex. It's to rebuild those coping skills. So think of this. If I'm, we'll go back to the instrument, right? I'm obsessed with instruments because I can't play them. So you practice an instrument over and over and over. What happens is there's a pathway built up in the cortex for that skill. And that pathway gets stronger and bigger and more wiring, and it becomes very complex the better you are at that skill. Well, coping skills are skills. And if you don't practice them, then the wiring pathways go away. They die off, they disconnect, energy goes to other areas. And so when someone starts using substances as their coping skill pathways die off. And so taking away the drugs doesn't rebuild that pathway. They actually have to put in work to build those skills and reset those pathways, or for young people, build them for the first time. Some of them probably never even had coping skills to begin with. So those pathways have to be built. That is the goal of treatment. Okay, without that, it doesn't matter what medication you put them on, it doesn't matter how long they go without using a substance, they will inevitably relapse if we do not work on the coping skills. I'm gonna skip that. So we gotta build up coping skills, we gotta build up stress relief, we gotta help them get social supports, we gotta help them go to a safe environment. The number one complaint I hear from first responders all the time, someone overdoses, we get called out, we give them Narcan, we bring them back, take them to the ER stabilizes them, sends them home, 2 hours later we get called, same person, same house, they overdosed again. They're frustrated. Sure, that seems frustrating, except for my first thought is, I'm sorry, they sent them where after they stabilized them? Back to the same exact place where they got all that dopamine to begin with? And we're surprised that they used again? That makes total sense to me, because that's what the addict brain craves. Spiritual growth and personal development, I have these here because this is the quickest, most efficient way to build up those coping skill pathways in the brain. The quickest, by far. It could take up to 2 years if you throw someone in a jail cell and don't teach them coping skills for their threshold for pleasure to come back to normal. If they work on their spiritual growth and personal development, the threshold for pleasure will move back down in as little as 90 days. Traditional treatments work in the cortex. Residential, intensive outpatient, partial hospitalization, those things work on the cortex. They teach coping skills. Medications work in the midbrain. Why? Because medications are drugs and drugs work in the midbrain, right? So medications that we use for alcohol and opiates, those are very, very helpful because they quiet this midbrain so we can work on the cortex. Doesn't mean that they are the answer. They are not going to solve the problem by themselves because giving someone medication does not fix their cortex. Giving someone medication and saying you won't get this medication unless you work on your cortex does work. The purpose of traditional treatment is simply to strengthen the cortex while they're actively craving, while the midbrain is active. That's it. That's the whole purpose. This is really hard to do when you have young people who don't understand desperation and don't know how to override an active midbrain, right? So it's very hard to get them to go to a meeting and sit down and listen to a bunch of old people tell them what to do. They don't even like to do that when they're not addicts, right? But especially when they're addicts, this is very hard. Young people have a hard time overriding their midbrain. But over time, with abstinence or with medication, this will happen. The threshold will come back to normal. But without the presence of coping skills, the immediate coping skill they will go to is to use again. And once they use a substance, the threshold immediately starts moving again. So it may have taken them 10 years of use for the threshold to start to go up, but now that it's broken, it only takes one time for it to start moving back up again. Okay, so like once a cucumber's a pickle, it can't ever be a cucumber again. Once the brain has this disease process, it will always return to the disease state. And punishment doesn't work by itself because, again, throwing someone in a jail cell or throwing someone in an institution and not working on their coping skills is not going to solve the problem. This is why people go to jail for 5 years or 10 years because of a drug-related crime. They get out, they say, I'm never using again, I've been clean for 5 years, and then their mom dies or their dog dies or something stressful happens, and they start drinking or smoking pot, and within a couple weeks, they're back on the drug that got them put in prison in the first place. And we're all going, what are you, crazy? Right? That makes no sense to normal non-addict brains. But it makes perfect sense when you consider that while they're in prison, they are not building up those coping skills. They're not working on that cortex. So abstinence alone will not work any better than a drug or medication alone. The purpose of the medication is simply the opposite. It's to quiet that midbrain so we can work on the cortex. That's all. And if I'm a chemical dependency physician, I never stand in front of a crowd and say a drug is the solution for a drug problem. That's stupid, right? That doesn't even make sense. But what I will say is it's a very useful tool in getting people to engage in working on that cortex. If a drug was the answer, certainly we'd have one pill to rule them all. It would be the precious pill, right? From Mordor or whatever. But we don't. We have a drug for opiates. We have a drug for alcohol. That's it. We'll probably have a drug for amphetamines at some point this year because that's what's on the rise right now. But my point is there's not one pill to treat addiction. So that means a pill doesn't treat addiction. But a pill can be, a medication used correctly can be a very, very useful tool when used properly in conjunction with traditional treatments. So the definition of addiction is this broken reward system due to unmanaged stress that results in loss of control, which is acting like a fool, right? Behaving in ways that are counterintuitive to one's value system. Craving, which is that physiological awakening of the midbrain, and persistent use despite negative consequences. If there are no negative consequences, there's no reason to stop using drugs, okay? But that could be medical, that could be physical, that could be financial, that could be emotional, that could be spiritual. A negative consequence can fall into any of the realm of possibilities. And if a loved one says to you, I'm worried about your drinking, and you choose to continue to drink, you have just placed alcohol over the concern of a loved one. You've placed alcohol over that relationship. You have just continued to use despite negative consequences. If you don't have a problem with a substance, it shouldn't be a problem not to use it, especially if someone that loves you is concerned about it. So, the organ is the midbrain, or the cortex. Actually, it's both. The disease is a broken reward system and a decreased overall functioning skill set, coping skills. And then the symptoms are loss of control, craving, and persistent use despite negative consequences. So if it's the same model as all the other diseases, and I'm even going to go a step further and say that if we continue this out and we say left untreated, what happens? There are more cases of spontaneous remission of cancer than there are of addiction, which means more people without treatment who have cancer will get well than people who have addiction that don't get treatment. So I would say that if we're going to put them on a hierarchy of better or worse, addiction is a worse disease to have. So 180 is primarily where I work, but I'll give you I'm going to give you 5 more minutes. If you'll give me 5 more minutes, I'll give you 5 more minutes. So most people want to know why do I do this? Because nobody likes addicts, they're a pain. And they are, I agree. But so why do I do addiction medicine? And the short answer is because I am in recovery, and I have been in recovery for 15 years. But I think that people like to know that yes, my addict patients can relate better or whatever, but I think that people need that hope shot. I think people need to know that you can be shooting heroin in the backseat of your car under a bypass in Newark and still come out the other side, finish medical school, and become the director of multiple facilities and speak at events. Because I think that people don't really think that they can get any better than just not using. And I want people to know that you absolutely can. And I am not exceptional. I mean, my mom would argue, but there's nothing really super special about me that put me in the situation where I could get well that someone else couldn't. Anybody that does what I did can be what I am. Anybody that follows in the footsteps of the people before them that made those same mistakes and has faith in that process will get well. And they will not only get well, but they will excel. And they can become amazing things, right? Not that I'm so amazing, but anybody can live their dreams. Anybody can come out the other side. And it's not, I think that people do have this tendency to sort of look at heroin as kind of this super bad. It's not, alcohol wasn't my drug of choice. Neither was marijuana. It was heroin. I was shooting heroin up until medical school. Actually, I was shooting heroin all the way into my 3rd year of medical school. Don't ask me how I did it. I have no idea because I was really high all the time. So I couldn't tell you. But I did it, and it got to a point where I couldn't do it anymore, and I had 2 choices. Kill myself, either on purpose or just overdose, or reach out for help. And by the grace of God, who I did not believe in at the time, I reached out for help, and it was available. It was there. And people pointed me in the right direction. And I'm going to tell you, I was that jerk that all of you know who's currently trying to get clean right now. I didn't want to do what anybody told me. I didn't want to go to residential. I didn't want to go to meetings. I bullshitted my way through that first year. I was just making stuff up and saying the right things, and I'm a pretty articulate person, so I was able to pull it off until I reached a place where I was 1 year without having used a substance and absolutely more miserable than I ever was using. And that's what it took for me to say, okay, I have a choice now. I can either pick up again, give up everything that I've worked for at this point, which basically meant I'd be kicked out of school and not have a way to pay back all those student loans, or I can actually start to embrace what these people are trying to give me and pay attention and listen and actually hear the words and hear the message and see what is in their hearts and see if that I can have that too. And I did it. And it was hard, and it was uncomfortable, and I hated it, and I didn't like you and your God, and I didn't like you and your stories, and I didn't care about any of these things, but I did it anyway because I was that desperate to get well. And medication wasn't really available at that time, so that wasn't really an option for me. So even better, now people can stop using heroin and smoking crack and drinking and smoking pot, because I was doing all those things, and stop doing all of the really shady behaviors that you do in order to pay for your drugs. Right? You can stop all of those things and make a choice to just follow the direction of somebody else who knows better, and then you can get well too. I mean, I think that's what people need to know. I think that's what they need to hear, right? Is that you can get well. And knowing what I know about addiction, only makes it that much easier for me to work with these addicts, to understand what they're going through, but also not to tolerate any of their nonsense, right? Not to give them what they want, not to enable them, because I know where they're at. I know you feel bad right now, and I know you think you know what's best, but I'm telling you, you don't, So I think that if you're gonna take anything home, take that. Take the message of hope, that anything is possible for an addict. It's a disease that, when treated, you can get really, really well. As far as all the other stuff, it's good, great, useful information and can help you be more compassionate, but it's also on YouTube, so you don't have to take it home. You can just watch it on YouTube. So with that, I will shut up, and if there's any questions, I'm available for questions. Yeah, I don't, one mic, there's one mic, is that what we're saying? Oh, she got a big, she says she has a big mouth.